Hi everyone, and in this video, I'll be discussing another interesting topic in CNS, that is opioids. Now, whenever we think of opioids, what is the drug which comes to your mind? Yes, obviously, the name is morphine. The name morphine is derived from Morpheus, the god of dreams. Opioids, when we think of opioids, we always think of the euphoric effect, the dependence, addiction history, then the use in medical therapy, that is mainly as a treatment for cancer pain and mainly in the usage of general anesthesia. So that is the story of opioids. Let us understand the pharmacology of opioids and what is the uses, adverse effect and contraindication of opioids, and we will also understand opioid de-addiction, right? So opioids. Now, what is the source of opioids? The source of opioid is from a plant called poppy plant, also called as Papaver somniferum. So from that we get a juice, and that is called opium, and that mainly contains morphine. So the source of opioid is the plant called poppy plant. So poppy plant is also called as Papaver somniferum, and from that we get a juice, that is opium. And in that opium, the major drug that is present is morphine. Now, morphine is natural occurring. So, usually morphine and natural occurring are called as opiates. So, usually the natural occurring are called opiates. Now, what we did later, we altered their structure and made them semi-synthetic, and we prepared exclusively in lab. They are called synthetic. So, opiates derivation from the source is like this: either natural, semi-synthetic, or synthetic. So, let me write them. Natural ones. So natural one is morphine itself. Then we have the codeine, then thebaine, and papaver. Papaver. Then we have the semi-synthetic. Semi-synthetic. So we altered the structure of morphine. So what we get is heroin, a derivative of morphine, and hydrocodone. Hydrocodone. Then nowadays we are synthesizing them in the lab itself. They are called synthetic. Example is fentanyl, and a drug by the name methadone. A drug by the name methadone and pethidine. So this is based on the derivation of the drugs. These are the opioid drugs. So once I understand the opioid, is there anything endogenous opioids in our body? Do our brain produce endogenous opioids? Yes, we have opioids already in our brain. They are called endogenous opioids. Now, what are the endogenous opioids we have? The name is endorphins. They are called endorphins. Remember when we discussed general pharma, I told you the placebos can release endorphins. And then we have enkephalins. Enkephalins. And one more group of drugs, the substance are called dynorphins. So these are endogenously present opioids. Now, when we think of opioids, these act on three important receptors: mu receptor, kappa receptor, and delta receptor. So opioids basically act on three receptors: mu, kappa, and delta. So the major action of endorphin is on mu, encephalin is in kappa, and dynorphins on delta receptor. These are endogenous. So once I know endogenous, what is the mechanism at the cellular level, how opioids work? Let us understand that. The mechanism of action of opioids at cellular level. Now remember, these opioid receptors are GI coupled receptor. So let me repeat. The opioid receptors are GI coupled receptor. You know, I means inhibitory. So they decrease the cyclic AMP. They open the potassium, close the calcium channels. So if I write the synapse here, this is the synapse, presynaptic terminal, and this is the postsynaptic terminal. Now the receptor mu are present presynaptically here, and the receptor is mu. And what type of receptor is it? GI couple receptor. Now, what happens when you activate GI couple receptor? There is decrease in cyclic AMP and there is opening of potassium. So potassium goes out, and who is not allowed inside? Calcium. Now, pause the video and just analyze. If potassium is going out and positive ion calcium is not allowed inside, will the cell become depolarized or hyperpolarized? Yes, hyperpolarized. So when the cell becomes hyperpolarized, there is decreased release of substance P, which is responsible for pain in the brain, and also decreases the release of noradrenaline, that is sympathetic. So when we use opioids, what are the effects we see? So opioids generally, since you decrease the substance P, they are known to produce analgesia. So we see an analgesic effect. Now when you decrease sympathetic, who will take over? Parasympathetic will take over. So what is seen is meiosis. So opioids can cause meiosis, and also they decrease sympathetic outflow, so they can decrease anxiety. Since you have suppressed the sympathetic system, patient can also have sedation. So this is the cellular level what opioids will do. So let me tell you again, GA couple receptors are, mu receptors are GA couple receptors, and they decrease cyclic AMP. They allow the exit of potassium, they open the potassium channel, don't allow the entry of calcium. So cell becomes hyperpolarized, presynaptic terminal, so there is decrease in substance B, there is decrease in noradrenaline. So what will lead to, because you decrease substance B, analgesia, decrease in noradrenaline, meiosis, decrease in anxiety and sedation are seen. So this is the cellular level. Now, once we understand the cellular level, what is the role of opioid receptors? So what is the role of opioid receptors? Now basically, I told you we deal with 3 different types of receptors: the mu receptor, the kappa receptor, and delta receptor. Now, what happens when you stimulate the mu receptors? Mu receptors are the one which can produce euphoria. Once they produce euphoria, patient will want that effect again and again, so they depend on the drug. So they are responsible for the physical and psychological dependence. Physical and psychological dependence in that patient or a person. Then the effect of mu is to cause meiosis. Yes, then constipation. It can produce constipation. And most important, analgesia, which can be used in managing cancer pain, and respiratory depression. So opioids, if you use them at higher dose, they can depress the breathing, that is respiratory depression. And why people addict to that? Euphoria. So there is euphoric effect and a very good sedation. So you can remember the actions of mu by the mnemonic, the PM cares. PM cares. What is the effect of kappa? The kappa effect are dysphoria. So what do you mean by euphoria? Patient feels pleasure. Patient feels like a king. What is dysphoria? Opposite of that. Patient feel like a beggar. He will have hallucination, delusions with that. He will have hallucinations and displeasure. So he will not have a very good effect with this dysphoria. And it is also responsible for causing meiosis, analgesia, and RD for the respiratory depression, and diaphoresis means sweating, and sedation. So it is also responsible for causing dysphoria, meiosis, analgesia, respiratory depression, diaphoresis, sedation. Delta receptors mainly responsible for producing analgesic effect. They will produce analgesia. So these are the effect of mu receptor, kappa receptor, and delta receptor when we use opioids. And majority of the actions of the morphine is on mu receptor. Remember, the majority of action of morphine is on the mu receptor. Please keep that in your mind. Okay, so now we know where do we get opioids from. We know the cellular mechanism of action, we know the receptors, and what is their effect on the person or a patient when we give it. So I just want to tell you now, when we take the morphine into consideration, the main drug in opioid, what are we going to see? So morphine, what are the morphine, or in general, we are going to see the opioid effect here. So the effect of morphine, we can understand by the mnemonic, please scream. So whenever anybody sees morphine, please scream. So morphine, please stands for, it is known to produce the physical and psychological dependence. Physical and psychological dependence. Now, why are we worried? The problem is patient has to take it again and again. Suppose if I stop the drug, patient will have withdrawal symptoms. He will have increased craving. So that's the reason these are abuse or addiction causing drugs, morphine. Now, in the scream, S stands for what? S stands for it is going to cause sedation. Now, what is the advantage of sedation? Particularly, it is useful to decrease the pain and also to have the anesthetic effects, because when we are using general anesthesia, we use opioids not only for analgesic effect, also they have sedative effect. Another important in smooth muscles. So what do they do in smooth muscle? Opioids. Remember, in smooth muscle, what do they do is they relax the longitudinal muscles and they contract the circular muscles. So the circular muscles are contracted. You know that in the intestine, the longitudinal muscles are the smooth muscles, and the sphincter we have the circular muscles. So what happens when you use opioids? What happens in the GI tract? In the GI tract, it will lead to constipation. So patient will have constipation because when you relax the longitudinal muscle, the motility decreases. There is decrease in motility. Yes or no? There is decrease in motility, and the sphincters will contract. So the patient will have constipation. What about GU? GU stands for genitourinary. There also same problem. The sphincter contract and the detrora relax. So there is urine retention. Urine retention. So because of these problem, usually we should avoid opioids in elderly because constipation and urine retention. Now, one important thing they will ask you is, what about in biliary? Biliary, we have the gallbladder, and there also it will constrict the sphincter of Oddi, so it can increase the biliary colic. So suppose a person has biliary colic, it will get worsened when we give opioids. Very much important question in your exams. Suppose a patient comes with undiagnosed abdominal pain, which drug you should not use? You should not use opioids because they contract the sphincter of Oddi and they will worsen the biliary colic further. So opioids are not at all used in biliary colic. Very much important. A repeatedly asked question in your exam. They are not used, contraindicated in biliary colic. So we are done with yes. So let us move on to the next letter, C. C, they are cough suppressants. Now remember, this cough suppression is not mediated by mu. So it is not mediated by the opioid receptors. So it is not mediated by opioid receptor, it's independent of that. So these are cough suppressant, and mainly what we use is codeine. Then once we know the C, then R for, again you can remember, retention of urine. Retention of urine, just I told you that. And if you want to add one more cough suppressant, you can use constipation, which is mediated by the opioid receptor. Then one more, remember morphine is derived from a plant. They are alkaloids. Usually plant alkaloids, when we use, they release histamine. So they release histamine. Now what is the problem if they release histamine? There are two problems. Number one, it causes vasodilation and decreases BP. So whenever we see a patient with opioid overdose, you can see hypotension. But that vasodilation is also important in managing something called left ventricular failure. We'll discuss that later. But release of histamine, it can cause bronchoconstriction. So opioids, particularly morphine group of drugs, are contraindicated in patients with bronchial asthma. So don't give opioid in a patient with bronchial asthma, very much important. So let me repeat, it releases histamine and it causes vasodilation, the BP falls, and histamine can cause bronchoconstriction, and that's why this morphine is contraindicated in a patient with bronchial asthma, very much important. One more important aspect I just want to tell you are for respiratory depression. These are going to cause respiratory depression at higher dose. So when you give the opiates more and more, suppose you want more analgesic effect and you try to give opiate more and more, patient respiratory depression also increases. Now why this respiratory depression? The simple example is, now we know that the medulla, we have vasomotor center, and that is in the brain, we have the center and we have centers in periphery. Now we have two drives to breathe. So what is that? When the partial pressure of carbon dioxide increases, then the vasomotor centers will get activated and person will breathe. So the carbon dioxide will be washed out. Or in the periphery, we have the aortic body, carotid bodies. So they are known to sense the decrease in oxygen. So that is called hypoxic drive. This is carbon dioxide drive. So whenever there is increase in carbon dioxide in the brain, the vasomotor center, that is in the medulla, they sense that and person will breathe. Now, whenever the hypoxia occurs, they will also give a signal, the person breathes. Now, what happens when we use opiates? The opiates will shut down this center which detects carbon dioxide. So, the carbon dioxide retention increases. What happens if carbon dioxide retention increases? It can also increase intracranial pressure. Since it increases intracranial pressure, we are not able to use this in head injury patients because the pressure is increased by them. Not only because of that, these are also vasodilators, so they can also worsen the edema inside the brain. So these are contraindicated in a patient with head injury because of carbon dioxide retention. Yes, that is fine, sir. Now, when the respiratory depression occurs, the reason is you have shut down the carbon dioxide center because the major stimulus is from that center. The minor is from hypoxic drive. So whenever the opioid poisoning occurs, if the patient comes with hypoxia, can I give oxygen? If you give oxygen, what happens? The only drive is hypoxic drive, you are shutting down and patient will go for further respiratory depression. So what you have to do in a patient with opioid overdose and he has come with the respiratory depression, the best one is naloxone and it's an opioid antagonist. Now when you give this is reversed and patient can breathe. Now if you want to still give oxygen, patient should be in ventilator, then only you can give oxygen. Otherwise, if the patient is opioid overdose and comes with respiratory depression, you see the oxygen is going down. If you give oxygen, his respiration will further come down. Very much important. That's why for opioid overdose, the antidote should be given is naloxone. It's an opioid antagonist. Now, why it is contraindicated in head injury? I told you, by retaining carbon dioxide, the intracranial pressure increases and vasodilation also worsens that. So that is R for you. So we are discussing the please scream, physical dependence and psychological dependence. Then S for smooth muscle sedation. Then C for cough and constipation. R for what I told you is the respiratory depression, then release of histamine, retention of urine. Then let us discuss the next word, and that is E. So why people get addicted? That is euphoria. Now, this is one of the effect where the patient feels pleasure. He feels like king. And that's why it is a drug of addiction. So euphoria. And second important, if they are in excess, opiates can induce emesis. Now why emesis? Opiates can stimulate the center called chemoreceptor trigger zone. They can induce nausea and vomiting. Now, is it mediated by opioid? No. It's independent of the opioid receptors. It is independent of opioid receptor. The opioids excess can stimulate CTZ and lead to nausea and vomiting. Then A for analgesia. So the major use of opioids in anesthesia as well as cancer is analgesic effect, and we can see two important analgesia, that is spinal as well as supraspinal analgesia. Spinal as well as supraspinal. Now what is the advantage of this? So they increase the tolerance to the pain. So when the pain occurs, patients are sensitive, they don't tolerate the pain, so that tolerance is increased, and also they decrease the perception of pain. So this is how they produce analgesic effect. Suppose you have a cut and you have pain. If the pain sensation you are not feeling that much, you don't have that pain feeling. So that is what the meaning of decreased perception of pain, and also the pain can be tolerable. Now what pain can we treat with this? Can we treat the musculoskeletal pain? Can we treat neuropathic pain? No. These are particularly useful in the pain, that is visceral pains, and particularly for cancer pain. These are very, very beautiful drugs, right? And the last word, M stands for meiosis. The M stands for meiosis. So this is the effect of morphine when we give to a patient. Please scream, the dependence, then smooth muscles, then constipation, cough, then retention of urine, release of histamine, then respiratory depression. Then we have euphoria, analgesia, and meiosis, all these things. Now one more important is they suppress the anxiety. So you can add one more point for A. They have anti-anxiety effect. So now we understood what are the actions of morphine. So once we are thorough with the concept, it's easy to learn the uses. Let's start that. So the opioid drugs we will be discussing under three headings. The first one are called pure opioid agonist. So they will stimulate the receptors of opioid, that is mu, kappa, and delta. Second, they are called complex acting opioids. You will understand why they are complex acting when I teach you. And third one is the opioid antagonist. So we will discuss under these headings. Sure? Yes. So the first one, what we are going to discuss are the opioid agonist. So in this opioid agonist, the first drug what we need to understand is the drug by the name morphine. The name of the drug is morphine. Morphine, pharmacokinetically, it undergoes a conjugation reaction called glucuronidation. So morphine undergoes glucuronidation, and we know that majority of the drugs undergo this process. Now when this is metabolized, you get two important molecules, morphine 3-glucuronide and morphine 6-glucuronide. Now this morphine 3-glucuronide can cause seizures if it is more. And remember, morphine 6-glucuronide, even it is metabolized, it is also highly active. So you have heard of active drug giving rise to active metabolite. So this is an active metabolite which is also highly active, and patient will have opioid effect with MC6, that is morphine 6-glucuronide also. So the point we need to understand is, now morphine, can we give it in renal failure? No, it is contraindicated in renal failure, or you have to reduce the dose in renal failure or decrease the dose in renal failure. So what happens if I give it in renal failure, or if I don't decrease the dose? The metabolites, that is M3G and M6G, they accumulate, and this will cause seizures, and this will cause opioid overdose, that is analgesia. That is fine, good only, but respiratory depression and other problems. So that is about morphine. So once we understood the pharmacokinetics of morphine, let us move on to the uses of morphine. So where do we use morphine? The use of morphine, number one, is particularly in the management of cancer pain. So one of the beautiful drug for cancer pain, morphine. Second important use is it is used in left ventricular failure or pulmonary edema. Now, left ventricular failure or pulmonary edema. Now, what is the common reason for this left ventricular failure or pulmonary edema? That is during myocardial infarction. So, why morphine is given during MI? The reason is not because it's analgesic, it has so many advantages. Number one, whenever the patient is having MI, they will have anxiety because when they get heart attack, they will feel that they are going to die. So, they will have anxiety. So, the decreases anxiety. It decreases anxiety. Second, it's a vasodilator. I told you he releases histamine. So it's a vasodilator, particularly it dilates the veins. And what happens? Because of that, it shifts the fluid, it shifts the blood from pulmonary to systemic circulation. So what is the advantage? When you shift it, the pulmonary edema will be managed. So what happens if there is lung with the fluid? Patient cannot breathe. So he will have breathing difficulty. So by shifting the blood from pulmonary to systemic circulation, it also decreases the dyspnea. That is, decrease the air hunger. So what is air hunger? Patient will not be able to breathe properly. Will be doing like this. So that can be decreased, and also it is known to decrease pain. So these are the two major use of morphine. One is cancer pain and mainly in MI. So in MI we could have used any analgesic, but why only morphine? Because these are the advantages. So these are the advantages. Now other uses of morphine are they are used in case of refractory cases of diarrhea and refractory cough. Refractory cough due to lung cancers, then we use it. Otherwise, the major use of this is in cancer pain and MI, and other use are refractory diarrhea and cough. So once we know this, they can ask you where morphine is contraindicated. Very commonly asked question in exams. Number one, you should not use morphine in head injury. Head injury patients, you should not use. Now, what are the reasons for that? Reason number one, I told you they increase carbon dioxide retention. So what happens if there is carbon dioxide retention? Obviously, there is increase in intracranial pressure. So in a patient with head injury, the bleeding occurs, the pressure inside the brain is already high. If you use them, it will be worsening that. Second, it will also cause respiratory depression. Already, head injury patient will have respiratory depressions, and this will worsen it further. And they cause meiosis. So what is the problem with meiosis? The progression of head injury you cannot assess because we check the pupil reflex in a head injury patient that cannot be assessed properly, and these are the reasons why it is not used in head injury. Second important condition is bronchial asthma. Anybody? Can you guess why morphine is not used in bronchial asthma? Yes, I told you the reason. Because morphine releases histamine. That's the reason. Now, third important is biliary colic. The reason why it is not used in biliary colic is it causes spasm of or contraction of sphincter of Oddi and worsens the biliary spasm or biliary colic. So this is a repeatedly asked question in exam. Yes. Now, whenever we think of morphine, it's always important they ask the morphine poisoning. So acute morphine poisoning. So acute morphine poisoning. So it may be seen in drug addicts or the patients who have overdosed it, or it's similar to the management of any opioid overdose, opioid poisoning. How to manage this? Now, what are the symptoms to look when the patient comes with this? Now, remember as CPR. So what is CPR? Patient with this will have coma. Patient will be having pinpoint pupil, that is meiosis. You know the reason for that. And patient will have the respiratory depression. So these are the classical signs of opioid overdose. In your exam question, they would have given a opioid addict or a cancer patient. Along with that, patient have pinpoint pupil. What are the other poisons where you see meiotic pupil? Where? You see it in OP and carbamide poisoning. You can see in Poynton hemorrhage. right? When it is the OP or carbonate poisoning, you will see a farmer and the symptoms of dumbbells are seen. But here similarly, you can see CPR. Along with that, there are three hypos. You see three hypos with that. What are the three hypo? The hypo, that is hypotension, BP, then hypothermia, that is low temperature, and hyporeflexia. So along with that, you see this. Now, what is the antidote for this? The antidote for this is opioid poisoning is called naloxone. So naloxone is the drug which is given intravenous. So that is the antidote. Now, whenever there is OP poisoning, should we do gastric lavage? Gastric lavage if the patient has taken intravenous. Pause the video and tell me. Suppose the patient has taken morphine intravenous and has come to the hospital. Should I do the gastric lavage? What do you think? So if he has taken IV, orally, yes, obviously we do it. But even though if he has taken IV, should I do the gastric lavage or not? Yes. If the patient has taken IV morphine, what happens? Now let me tell you this. This is the stomach. This is the intestine. You know that from general pharma, morphine is basic drug. Now even the patient has taken morphine by the intravenous route, morphine gets secreted in the stomach. So stomach pH is acidic and morphine is basic drug. So you know that when the basic drug comes in acidic medium, it will be non-ionized, that is not absorbed. So if it is not absorbed, it is coming out, it is trapped there. So when you do gastric lavage, morphine can be thrown out again. So that is the advantage of doing gastric lavage even when it is given IV, if it is taken IV. Very important point. But if it goes to the intestine, it will be absorbed. So that's the reason gastric lavage has to be done whenever the morphine gets secreted into the stomach. When the gastric lavage is done, it is helpful. So that can be asked in exam. So that is the story of the first drug, morphine. Yes. So similar to morphine, we have a second drug and the name is called pethidine. A very beautiful drug. Pethidine, it has one more name, meperidine. It is also called as meperidine. Now actually pethidine is a derivative of atropine and it has the anticholinergic property. So it's a derivative of atropine. So that means you will see the anticholinergic adverse effect, that is dry mouth, blurring of vision, constipation, urine retention, all those things. Now, because it has atropine derivative, it possesses anticholinergic property. And what about, will it cause meiosis or mydriasis? Less chance of meiosis. Usually opiate should cause meiosis, but here pethidine may cause mydriasis in certain patients because of anticholinergic property. And why did we use morphine in MI patient? We told them that. But here it is known to increase heart rate, tachycardia, and we should not use it in MI patient because of this. Now another important advantage is this has less effect on biliary spasm. So biliary, GI, GU, it has less effect. So it will not cause so much of constipation, it will not cause so much of urine retention. And can you use it in biliary colic? Yes, you can use it. So what are the uses of pethidine? Number one, it can be used as analgesic. That's a major use. It is used as analgesic. Remember, when we compare morphine and pethidine, morphine is, if I use morphine at 1 milligram, pethidine I should use it at 10 milligram of pethidine. Now, you correlate general pharma here. To get the analgesic effect, if I require 1 milligram of morphine and I require 10 milligram, who is more potent? You know that dose and potency are inversely proportional. So morphine is the most potent. And pethidine is less potent comparatively. So that is the dosing. Second question is, since it is a opioid, can we use it in biliary colic? Morphine we didn't use. So if the question arises, will you mark it as true or false? True, because it's an anticholinergic property, so it can relieve the spasm, biliary colic. So it can be used. And importantly, in most of the books give it as drug of choice for post-operative shivering. So it is a drug of choice for post-operative shivering. The mechanism is unknown, but some of the books tell it is due to alpha receptor, that is alpha 2 receptor mediated action. So that is about pethidine. So compared to morphine, what is the difference? Pethidine is also called as meperidine, but it has anticholinergic property. So it is a drug which increases the heart rate. It causes mydriasis and less chance of meiosis, and it has the less action on the biliary tract, genitourinary tract, and GI tract. So analgesic, biliary colic, and drug of choice for post-operative shivering. Now pethidine is also important pharmacokinetically in certain situations. Now when I talk about pethidine metabolism, pethidine is converted to two important compounds. One is called meperidinic acid, and one more is norpethidine. Now this norpethidine is excitatory for the CNS, and patients may develop seizures. So this pathway is less and this pathway is more. So most of the pethidine when we give normally, we get meperidinic acid and less of norpethidine. That's why no problem, patient will not get seizures. Now who will do this process? This is done by the process called hydroxylation. That is the phase 1 metabolic pathway. And who will do this? Lesser. This is done by demethylation. This process is done by demethylation. Now, why should I study this, sir? Why should I study this? Because when we use pethidine with a MAO inhibitors, monoamino oxidase inhibitors, what do? The MAO inhibitors, let me write them. MAO inhibitors, they inhibit the hydroxylation step. Hydroxylation step is inhibited. Now what happens? More of the pethidine will become norpethidine and patient will have seizures. So the message here is don't combine pethidine with MAO inhibitor. What happens? Methadone is converted more to norpethidine and patient may have CNS excitatory effect, that is seizures. So drug interaction is don't combine pethidine plus MAO inhibitor, very commonly asked question in exam. Another important, don't combine pethidine with SSRIs. The reason is pethidine is known to increase serotonin release, 5-HT release. So when you are using two drugs which are increasing serotonin, they are known to produce a syndrome called serotonin syndrome. So that is the reason why we should not combine them together. So drug interactions, pethidine should not be used with MAO inhibitor, not with SSRI. Why not with MAO inhibitor? The reason is seizures. Okay, we understood that. Very beautiful drug, pethidine, the second drug. So first one is morphine, second one is pethidine. The third drug, what we are going to discuss, is a drug by the name codeine. The name is codeine. So codeine directly has cough suppressant effect. It's a cough suppressant. So if it is a cough suppressant, which cough should we use it? It is mainly used in dry cough. We use it in dry cough. But codeine in the body is converted into one more, that is morphine. So codeine is converted into morphine, and morphine will produce the effect like analgesia, sedation, and euphoria. So because of this, there is a problem with codeine, addiction problem. So if we prescribe the patient codeine, they will get the beautiful effect of analgesia, sedation, euphoria. They tend to addict. So that's why codeine is a prescription drug. It's not an over-the-counter drug. Few years back, it was OTC. Now it is prescription drug. Now what is the enzyme which will convert that? It is the cytochrome 2D6. Suppose a patient is not producing this enzyme. He is a poor metabolizer. Meaning of poor metabolizer means they are not producing the enzyme properly. For them, if I give codeine, they will not get the analgesic effect. But what effect is seen? They will only get the cough suppressant effect. So that can be a potential question in your next exam. Similar to codeine, we have one more, full codeine. It is also used in dry cough. It is also used in dry cough. Yes. So one more drug is dextromethorphan. Now dextromethorphan is a derivative of opioid. It's a derivative of opioid, but it is not going to act through the opioid mechanism. It is a NMDA blocker. It's an NMDA antagonist, and that is also used in dry cough. It is also used in dry cough. So these are the drugs which are used as cough suppressant. So we will be discussing this again in respiratory pharmacology. So that is the drugs. Now moving on to the fourth drug, a very beautiful drug, methadone. The name is methadone. Methadone is a mu agonist, fine. It's a mu agonist, correct. But not only that, it has other actions also. It's a NMDA. It's a NMDA antagonist. So antagonist or a blocker. And also one more specialty, it inhibits 5-HT and noradrenaline reuptake. The question in the exam is, if it inhibits serotonin reuptake, can we combine with MAO inhibitors? No. Can I combine with SSRI? No. There is a risk of serotonin syndrome. Now, the pharmacokinetics is very much important. It has slow onset of action. It will not work immediately. The action is slow onset of action, and it is longer acting. So since it has slow onset of action and it's longer acting, it is used in opioid de-addiction program. Opioid de-addiction program. So where do we use it? Methadone is used in two important places. One is to manage the cancer pain, and in opioid de-addiction program. Opioid de-addiction, that is methadone for it. Now, the next drug, the fifth group of drug, we took the advantage of constipation and we use drugs for that, and they are called loperamide. And we'll discuss again these drugs in GAT pharma. Loperamide decreases motility of the intestine. Not only that, it also decreases the secretion and it closes the sphincter. So the name is loperamide. Now loperamide, it is used in the management of secretory diarrhea as well as traveler's diarrhea. So we'll be discussing in detail this loperamide in GAT pharma. Anyway, let me also tell you certain other points. It is contraindicated in a patient with infective diarrhea. Now, why it is contraindicated in a patient with infective diarrhea? Because when there is infection, if you stop the motility, if the stools are not going out, the bacteria may grow and the infection may flare up. That's why contraindicated, and it is not used in less than 4-year children. It may cause paralytic illness. So the intestine may become paralyzed because you are decreasing the motility. Similar to loperamide, we have another drug. It is called difenoxylate. The name is difenoxylate. It is same. It is also used for the secret diarrhea and traveler's diarrhea, but the advantage of loperamide is it doesn't cross the blood-brain barrier. So the addiction problem is not there. But difenoxylate crosses the blood-brain barrier and patient gets euphoric effect. Now the problem is patient gets euphoria. Why are we giving this? We are giving it for diarrhea and he is getting euphoria. So he will forget the diarrhea and start using it, and that is for abuse. So what the government thought, if you want to give difenoxylate, you should always get a combination of atropine, because atropine will also cross and patient will have delirium here. That is confusions, hallucination. So he will not take it again and again. So this is combined to decrease the abuse potential. So the combination is given to decrease abuse potential, It's again a question, is this combination rational? Yes. The question is, should we use loperamide with atropine? No need, because it will not cross the blood-brain barrier, so no need for that. That is about loperamide and diphenoxylate. The sixth category of drug, they are called tramadol, and one more drug called tapentadol. Now these drugs are not going to produce full mu agonism, they are partial mu agonist, and second, they also inhibit 5-HT and noradrenaline reuptake. So what should I remember for them? Remember tramadol, tapentadol, they can ask you a question, which are the opioids which have opioid and non-opioid mechanism? Opioid means they act on mu receptor or kappa receptor, delta receptor. Non-opioid mechanism is they inhibit 5-HT and noradrenaline reuptake. So this is the advantage, and they are used for chronic pains. Now chronic pain patients will have depression also, so this will also help in managing some depression. So the advantage is they also inhibit 5-HT and noradrenaline reuptake, and they are used in chronic pain. Right. So we are done with the next group of drug. There is a drug called papaverine. I told you, a naturally occurring one, and we use it as injection locally, and it is used for erectile dysfunction. The name is papaverine. The next one is called propoxyphene. So propoxyphene is one of the least potent drug, and it is used as analgesic with NSAIDs. Analgesics with NSAID. The name is called propoxyphene. Now, if you know propoxyphene, similar to that we have one more, and that is called levopropoxyphene. So levopropoxyphene is a cough suppressant. It is used for dry cough. So we'll discuss this drug again when we come to RS Pharma. So it is used for dry cough. Now later we came with another class of drugs. Moving on to the next opioids, they are called as synthetic opioids. So the name itself is telling you that they are synthesized in the lab. And most of the synthetic opioids, their usage is in the cancer therapy as well as general anesthesia. So the first drug in that is a drug by the name fentanyl. Now fentanyl is 80 times more potent than morphine. It is 80 times potent than morphine. It is 80 times potent than morphine. We give fentanyl in the form of patch. We have something called patient-controlled analgesia. Then it is also available as fentanyl lollipops for cancer pains. So major use of fentanyl is two important aspects. One is in cancer pain, and one more is in general anesthesia. The name is fentanyl. Similar to fentanyl, we have a drug by the name sufentanil. Sufentanil is 1000 times potent than morphine. 1000 times potent than morphine. And also it is highly plasma protein bound. And that makes the drug longer acting. Then other drugs are alfentanil. Alfentanil is a synthetic opioid which is used for total intravenous anesthesia, TIVA. Then we have a drug called remifentanil. The drug remifentanil is a shorter acting. It is shorter acting synthetic opioid. The question is why it is a shorter acting, because it is metabolized by the enzyme esterases in the plasma. And since the drug is shorter acting, it is preferred in daycare surgery. And the name is called remifentanil. Remember, these are synthetic opioids: fentanyl, sufentanil, alfentanil, and remifentanil. And all these synthetic opioids they are known to produce post-operative muscle rigidity, and the chest wall will be rigid. So we call it as wooden chest syndrome. That's the complication what we see with synthetic opiates. So the name are fentanyl, sufentanil, alfentanil, and remifentanil. So let us understand how to manage acute morphine poisoning. Acute morphine poisoning, or what we mean by the opioid overdose. Opioid overdose. So how do you diagnose acute morphine poisoning? Remember the mnemonic CPR. What is CPR stands for? The coma. Patient will have the pinpoint pupil, and patient will have respiratory depression. Along with that, patient will have hypo. There are three important hypos. What are those? Hypothermia, hypotension, and hyporeflex. So these are typical of the morphine or opioid overdose. Now please remember, there are other poisoning also where you see the pupil becoming myotic, the Poynton hemorrhage, the OP and carbamide poisoning. In OP and carbamide poisoning, along with the pinpoint pupil, the patient will have the symptoms of dumbbells, diarrhea, urination, bronchoconstriction, as well as the MSS, lacrimation, salivation. There the respiratory rate would have been increased. And what is the antidote for the OP or carbamide poisoning? It's atropine. But here, the antidote for this poisoning is naloxone. So the antidote is naloxone. We give it at 0.2 to 0.3 milligram every 2 to 3 minutes. So we give it every 2 to 3 minutes till respiration picks up. Because the major problem in opioid overdose is respiratory depression. Now, as per any poisoning, we do the same airway, breathing, circulation, and along with that, should we do gastric lavage? Yes, we can give gastric lavage for this patient if he has taken orally. Sir, if the patient has taken IV morphine, still should we give gastric lavage is a question. Now, when it happens when the patient has taken IV morphine, we know that morphine is a basic drug. And let me draw the stomach here, intestine. This is the stomach. This is the intestine. Now, what happens when the patient has taken high dose of morphine IV? There is a chance that it also gets secreted in the stomach. So, morphine is a basic drug, and the pH in the stomach is acidic. So, at this point, the drug is ionized. So, the drug will not be absorbed, and again it will come back. It becomes non-ionized in the small intestine, because small intestine, the general pharma, it is little basic, and drug is basic, so it is again reabsorbed. So there is a chance of reabsorption. That's the reason why we have to do the gastric lavage and remove the poison out, even if the morphine is taken IV. So the management is same thing, ABC, gastric lavage, and the antidote is naloxone. It is given IV. Please remember, obviously IV because it's an emergency. 0.2 to 0.3 milligram every 2 to 3 minutes till the respiration picks up. That's the drug of choice for opioid overdose or acute morphine poisoning. So the second category of opioids, what we are going to discuss, they are called complex acting opioids. Complex acting opioids. In complex acting opioids, there is an opioid which is called the partial mu agonist. So it's a partial mu agonist and a kappa antagonist. So that's why they are called complex acting opioids. So what is that partial mu agonist and kappa antagonist? The name is called buprenorphine. Now, since the drug is partial mu agonist and it is not going to produce so much of the effect, so what is the drawback? They have less efficacy. But they are more safer to use. And the third advantage is they have a ceiling effect. they have a ceiling effect for respiratory depression. Sir, what do you mean by that ceiling effect? Now, if you are sitting in the home, you can see the ceiling. Now, after this, you cannot go up. Ceiling is blocking you. Okay, you can go by steps. That is secondary. But what happens when you use opioid? As we increase the dose, the respiratory depression also increases. Because we want more analgesia, that means more respiratory depression. So here, even if you increase the dose, the respiratory depression will reach a level. After that, it will not depress further. So that's why it is very safe to use. So where to use buprenorphine? It is used in analgesic. It's an analgesia, and it is also used in opioid de-addiction program. Opioid de-addiction program. So that is the story of the partial mu agonist and kappa antagonist. Now moving on to the another category of drugs, they are also complex acting. You can see the mechanism which is complex. They are mu antagonist and kappa agonist. They are mu antagonist and kappa agonist. Now, what is the problem if the drugs are kappa agonist? Patient will have dysphoria. So, he will not have the good feeling, he will have dysphoria. Now, what are the drugs in this category? The name is pentazocin, and we have a drug by the name nalbuphine. We have the name nalbuphine and buterphenol. The name is buterphenol. Now, buterphenol is a nasal spray, and it is used in cancer pain. So, the nasal spray is used for managing the cancer pain. So, these are the mu antagonist and kappa agonist. So, let me take the example of pentazocin and explain to you. Pentazocin. So, this question had appeared recently. It's a mu antagonist. It's a kappa agonist. Not only that, it has shown some partial mu agonism also. It's a partial mu agonist. So that's why the action is complex. Now, another important aspect is it increases the sympathetic activity. So it increases the heart rate. But one more advantage is less biliary colic. So less biliary spasm and less effect on the GI or GU. So the gastrointestinal and genitourinary problems are less. So biliary colic, it will not cause a problem. So that is pentazocin. Main use is used as analgesic. It is used as analgesic. Now the question asked in your exam is, suppose a person is opioid addict. He is a heroin addict. Let us take in the example. Now if he is a heroin addict and he comes with pain, can we give pentazocin? No, because pentazocin is a mu antagonist. Now, if you give an antagonist to an addict, he will go for withdrawal symptom. Because when you give an antagonist, they block the opioid receptor. Patient opioids are not going to work and he will go for withdrawal symptom. So remember, if opioid addict has come with some other pain, and if you want to give pentazocin, don't give it. Patient may go for withdrawal symptoms. Okay. So this is the importance. So once we know the complex acting opioids, so it is time to understand another category of drugs. These are called pure opioid antagonist. Pure opioid antagonist. The name is because they block all the receptors. That is mu, kappa, delta. All the three are blocked. If you see the complex acting, some are stimulated, some are blocked. That's why these are called pure. Now in this we have two categories. The centrally acting and one more is the peripheral acting. Peripheral acting drugs. Now what is the meaning of this? Centrally acting, they enter the brain. They cross the blood-brain barrier and they can work in the brain. Peripheral acting, they don't enter the brain. They act in the periphery itself. So in centrally acting, we have two important drugs. One that is given intravenous and the one which is given oral. The one which is given intravenous and one which is given oral. So what is the intravenous drug? The intravenous drug is called naloxone. The name is naloxone. Now naloxone is the drug of choice for opioid overdose or opioid poisoning. Now it is also used in one more, obstetrics. So it is used in obstetrics when opioid is used during labor. Now what is the problem here? So nowadays we have the concept of painless labor and we use opioids. When you use opioids, the opiates can enter the fetus. The level of opiates may be more to the fetus. When the baby is born, the baby may have this overdose and may have respiratory depression. How do you reverse that? That is done by naloxone. So when opioid is used during labor and baby born had respiratory depression, how do you reverse it? By using naloxone. So the question asked in exam is, if you are using opioid during delivery, what injection will keep ready? Obviously it is naloxone. So that is the specialty of naloxone, and we have one more drug which is given IV, that is called nalmefene. Okay, so particularly you have to remember for exam the main drug is naloxone. What about the oral drug, sir? The oral drug is called as naltrexone. Naltrexone. Remember, it's an oral drug. Don't confuse naloxone. It's an IV drug. What are the uses of this? Number one, it is used to decrease craving in alcohol. Craving in alcohol. Next, it is also used in opioid overdose. But it's an oral drug, so it will not work immediately. So once a patient from ICU is shifted to ward, then you have to give it, then give it. And it is also used in management of obesity. And it is also used to decrease relapse in opioid addicts. Relapse in opioid addicts. So that is the name naltrexone for it. Naltrexone. So these are all the central acting, they cross the blood-brain barrier. Suppose somebody has taken morphine will enter the brain and respiratory depression. So naloxone has to enter the brain and block it. That's why these drugs should cross the blood-brain barrier. Now, where do you use peripheral acting? Peripheral acting, these drugs, for example, a patient has cancer pain. So patient has cancer pain, and if I am giving morphine to that, so we want the morphine to enter the brain and produce action there, so that the pain decreases. Now, the problem when we give morphine to the patient is, on long-term use, they will develop constipation. So if I want to manage constipation, I have to block the effect of morphine in the intestine. But if I give a drug which enters the brain also, the morphine effect to decrease the pain will also go away. So I will use a drug which will not cross the blood-brain barrier, but it will block the morphine action only in the periphery. And these are used for opioid-induced constipation. So peripheral acting opioid antagonists are mainly used in opioid-induced constipation. So let me write them. Peripheral acting opioid antagonist. So what are their name? The name is methyl naltrexone. So don't confuse naltrexone because it enters the brain. This is methyl. So the group is added, so it will not cross it. Then we have naloxegol and a drug called naltamidine. Now all these drugs are used for what condition? Opioid induced constipation. So we'll discuss this topic again in GI. So if you know this earlier, it's easier. Now another drug which is a peripheral opioid antagonist is called alvimopane. The name is alvimopane. It is used to treat paralytic ileus. Paralytic ileus due to what? Due to, let me push it here, due to gut resection surgery. So after the gut resection surgery, if there is paralytic ileus, it is approved for that. The name is albumapan. And remember, albumapan can increase the risk of MI. Increase the risk of MI, and that is a black box warning given for this. Black box warning given to this. And that is the reason it is used in limited dose program. You should not use it for more than 15 dose. So it should be used within 15 dose only, 15 dose only. Not more than that, the risk increases. So it is approved for limited dosage program only. So this is what we mean by the opioid antagonist. So until now, what we have understood in opioid is what is the source, the plant, that is poppy plant, and the opium juice. Then we understood the cellular mechanism. They are GA couple receptors, mu, kappa, and delta. Then we understood the PM cares action, and then the delta action, then kappa action. Then we discussed what is the effect of morphine, please scream. Then we discussed the various drugs, the synthetic opioids, and then we discussed complex acting opioids, and then pure opioid antagonist. So once we understand this, now it is important that we understand certain important application of this. Sir, what are the applications I need to understand here? Now, when we use opioids, certain effect of opioid develop tolerance. What is tolerance? If I use the drug repeatedly, the receptor become desensitized. The receptor becomes desensitized. That is tolerance. For example, if I am giving a drug 10 milligram for analgesia, so patient will get pain relief with that. So when I use that repeatedly again and again, the analgesic effect is gone. So you have to increase the dose further, 20 milligram. After a few months, 30 milligram to get the same effect. So that is called tolerance. To get the same effect, you have to increase the dose because the receptors have become desensitized. Now there are three effects of morphine. There is no tolerance. No tolerance developed these three effects. The commonly asked question in exam, what are the three? So you can remember as 3 C's. What are these? Convulsions. So they don't develop tolerance. Then C for constriction of pupil. Whatever dose you give, it will be seen. That is meiosis. And one more is constipation. So they don't develop tolerance. All other effect, that is sedation, analgesia, euphoria, they all develop the tolerance. Now, when the drug is giving so much of euphoria, people will tend to addict to that. So because of that, patient develop dependence. Now there are two important dependence. One is the physical dependence and the psychological dependence. Physical and psychological dependence. Now, what is the meaning of physical dependence? If I stop the drug, when I stop the drug in this case, patient will go for withdrawal symptoms. Patient will go for withdrawal symptom. If it is psychological dependence, if I stop the drug, patient will have increased craving to get the drug. So he will have more craving towards the drug. Now, what happens if I stop the drug? Why the withdrawal symptom? Just imagine. Now, this is the synapse I told you. When patient was taking opioid, the receptor is mu, and mu was decreasing the norelin and decreasing the substance P. So when you are using this for a very long period, this is stimulated by the opioids. Now, when suddenly you stop it, what happens? Because you are not giving them for a very long time, the receptors would have increased in number. So when you suddenly stop that, the norelin increases. So when the norelin increases, the patient may develop anxiety, patient may develop insomnia, and increase in substance P may also increase pain, analgesia, or what we call it. We can call it as hyperalgesia. So when you suddenly stop, they will increase and the patient will develop this. That is the increase in pain, insomnia, anxiety. Along with that, patients with withdrawal symptoms, they also develop other problems like yawning, increase in secretion like increase in salivation, lacrimation, and sweating. So these are not related to the sympathetic activity, that is salivation, lacrimation, yawning, right? And sometimes patient also complain of muscle rigidity, muscle rigidity or cramps. Yeah, this is what we see when the opioids are stopped, and this is withdrawal symptom. Now the problem here why the anxiety insomnia is because noradrenaline is released. Now there is a drug which can stop this. Now this drug which can be used to treat noradrenaline release is alpha 2 agonist. And what is the name of alpha 2 agonist? That is called clonidine. So to treat withdrawal symptoms, what we can use is a drug by the name which is alpha 2 agonist. The name is called clonidine. And one more is called lofexidine. One more is lofexidine. Oh, these are the things. Okay, so we understood what happens if they stop the drug. These are the symptoms of opioid withdrawal. They can ask you. It's a not only pharma question, it's a psychiatric question also. These are the symptoms what we see. So particularly yawning, the salivation, lacrimation, then anxiety, insomnia, increased pain, cramps, all these things will go for that. So the point here is when the patient has withdrawal symptom, you can do one thing. You can decrease the sympathetic release, that is alpha 2 agonist, or you can do one thing. The reason is because of withdrawal. So what you can do is you can give the mu agonist only. So patient having withdrawal symptom, you can give opioids only to manage this. So let us understand that. Now patient has opioid withdrawal. So how do you manage opioid withdrawal? So how do you manage the symptoms? Symptoms are managed with alpha 2 agonist. The alpha 2 agonists are clonidine, and one more new drug is called lofexidine. Second, sometimes benzodiazepines are also used to sedate a person. Now, the reason for opioid withdrawal reaction is because you are not giving opioid. Instead of that, you can replace opioid. So replace opioid in the form of longer acting and partial ones, that is methadone, as well as you can give buprenorphine. Any of this can be replaced. So this is how we manage opioid withdrawal reaction. Okay, hope you are understanding these points. So that is opioid withdrawal reaction. So suddenly when you stop opioid, patient will go for the symptoms. The next important thing is how do you de-addict? Opioid de-addiction. So opioid de-addiction. So patient has come to us and he is telling that I am addicted to opioid, I want to quit it. But a problem, if he quit himself, he will go for a withdrawal symptom. So we should do a program for that. So opioid de-addiction, what we do is, patient is getting a kick because you are stimulating the mu receptor. So you take an example. Suppose you take the example of cricket. There are three formats of cricket: T20, one day and test cricket. Now what cricket will give you the kick or the fun? T20 cricket. Now you are addicted to that. But if I remove you from cricket, you will go for withdrawal symptoms. So what I will do, I will give you cricket, but I will give you test cricket. So you will not go for withdrawal symptom and you will not get that much of kick. And then you will gradually stop watching that. So keeping that in the mind, now what we have done is, instead of giving the fast acting opioids or full agonist, what we can do is, we can give a long acting and slower acting methadone, or we can give buprenorphine. So it is called methadone maintenance therapy. Now once we start a patient on this, then gradually taper the dose. Gradually taper the dose and then stop these drugs. But many times problem is when they are taking methadone, methadone is a mu agonist. So that can also give kick. So if they are already heroin addict, what they may try is they may take methadone more and they can also become toxic with that. So you should monitor when you are using this methadone maintenance therapy also. It's not like you give it and then leave like that. So monitoring is very much important. Now, once a patient is addicted, patient is de-addicted, another important thing is there is a chance of patient becoming relapse. Now, what if relapse? He may become addicted again. Now, patient will tell that he may have a chance, because if he is along with the drug addicts, again, if you de-addict and send them, if friends are there, he may have a chance. So if they have a chance, there is a relapse. So what we do is, if they are relapse, after stopping this, what we start them is in naltrexone. Now, if this is the opioid receptor and the patient is on naltrexone, naltrexone blocks the receptor. Even though after de-addiction program, if he goes with the friends and friends force him to take the morphine or heroin, now he is already taking naltrexone. If he takes heroin, heroin cannot give the kick to him because the receptor is already blocked. So that's the reason, to prevent or decrease relapse in opioid addicts, the drug used is naltrexone. You may ask a question, sir, why don't we use it in the de-addiction program only? Suppose this is the opioid receptor and I use naltrexone, it will block it. So if I don't replace and give naltrexone in the beginning only, patient will go for withdrawal symptoms. So we don't want that to happen, and we don't want to take the risk. And even if you take the risk, again, you have to replace the opiates only. Sir, what about this? Will not be a problem here because already patient is de-addicted. If you give naltrexone, nothing will happen. So this is the understanding. One more beautiful cases let us take up into consideration: opioid in pregnancy. Opioid in pregnancy. Let us take this. So let me give a case like this: case 1 and case 2. Now, in case 1, opioids were used during delivery. Opioid was used in labor. So what happened? The baby was born. The baby born had respiratory depression. Second case, the mother, the pregnant woman, she is an opioid addict. She is an opioid addict. She is an opioid addict. Now, the baby was delivered. And the baby born was irritable. Now, what will you give here? And what will you give here? What will you give here and what will you give here? Just pause the video and try to answer this. Now, I think case 1 we have already explained to you. Now, when we use opioids during labor, sometimes what happens, the dose may be higher to the baby and it may have respiratory depression. Suppose the baby is showing hypoxia, never give oxygen alone. First, you have to give the drug of choice is naloxone. So naloxone is the one which can reverse the respiratory depression. So they can ask you what injection you'll keep ready when opioids are used in delivery. Now the case 2, the baby is delivered and it is irritable. Why? Because when a pregnant woman is an opioid addict, the baby is also dependent on the opioids. Now when the delivery happens, the baby is withdrawn. So baby is having withdrawal symptoms. So when the baby is having withdrawal symptom, if I give naloxone, it will worsen further because it will block the opioid receptor and withdrawal symptoms will worsen. So here what we do, we replace the opioid, that is methadone, or we give morphine to the child. So the newborn will be given this and the dose is gradually taper and then stop. So this is what we do in the pregnancy. Very important, very interesting cases. So guys, I hope you understood the opioids and why it is important to learn opioid, because one of the beautiful drug for cancer pain and most extensively used in anesthesia practice. Okay, so just remember the most important is mechanism of action. There are 3 receptors: mu, kappa, delta. They are GI coupled receptor, and the main drug is morphine. And morphine is contraindicated head injury, asthma, as well as biliary colic. Pethidine is different. It is an anticholinergic property. You can use it in biliary colic. Tramadol, tapentadol, and methadone, they have non-opioid mechanism. They inhibit 5-HT and noradrenaline reuptake. The complex acting opioid pentazocine, it's a mu antagonist, partial mu agonist, as well as kappa agonist, and it produces dysphoria. Buprenorphine is a mu partial agonist and kappa antagonist. The pure opioid antagonists are naloxone, drug of choice for opioid poisoning, and also it is used if there is respiratory depression when we are using opioid during labor. The oral drug, which is an opioid antagonist and it crosses blood-brain barrier, is naltrexone, which is used in alcohol, obesity to decrease relapse in opioid de-addiction program. So these are very much important, and that is about opioids for you. Thank you all.